screen and get started, and hopefully you can see my slides. As was introduced, I'm in the School of Health Professions. I also do work in the Informatics Institute. So I'm going to start with a little bit of information about me and my background and how I got to UAB, and then I'm going to talk about our program, and then I'm going to talk about some research that's coming out of our department from the Health Informatics faculty, and then I'm going to show you some of the work. So that's kind of what I'm going to talk about today, and the order. And then I'll leave plenty of time in the end for all kinds of questions that you may want to ask. So a little bit about me. As was mentioned, I'm a nurse. I spent a couple of decades in pediatric open heart, open lung major trauma and air and ground transport at Children's Hospital in Los Angeles. Spent the majority of my life in California, and moved here almost 5 years ago. August will be 5 years. And boy, time flies. It's just hard to believe it's been that long. So I came here and started my work at UAB. And coming from California to the South was a little bit rough. But now I love it, and the thing that has kept me here has really been our department, which is just a super place to work. It's a super place to build programs and deliver education and conduct very, very innovative research, some of which I'll show you at the very end. A little bit more about my background. After nursing, I took a couple of twists and turns, and my kids were almost grown. I have 2 boys, and they were almost grown, and I decided it was time to do something for me. I felt like I had pretty much been doing everything for my kids and my family, and so late in life, I went back to graduate school and decided that I was going to get a terminal degree. I really had no idea what that meant. It was like, I'm just going to do something for myself. And so off I went, and I wanted to try and somehow marry together my clinical background, my education background. I missed in there that I taught elementary school for 7 years and taught adult teachers during that time as well, and really loved education. And when I was at Children's, I was a preceptor for new nurses. So I really liked teaching. And I was pretty self-taught on information systems. And so I thought, how do I put all that together? Health informatics wasn't really a thing. And I couldn't find a graduate program that could put them all together for me. And so after talking with numerous graduate programs, I finally wound up at Claremont Graduate University, who said, well, we don't really do that kind of thing. And I said, well, because you don't, does that mean that you won't? And they said, well, let's think about it. And so long story short, I wound up getting my degrees at Claremont Graduate University. And it turned out to be a really good thing. For me, my dissertation was on the value of health information exchange using what was then the Nationwide Health Information Network, what is now eHealth Exchange. In grad school, I delayed my graduation by a year to do an internship at the Social Security Administration, because they were the first implementers of eHealth Exchange. And so this is kind of an interesting story, and I tell this story because it was pure happenstance that internship happened, but it really defined my entire career. And so the way that this happened was that I was at HIMSS, which is a global conference of Health Informatics people, 45 to 50,000 people, happens annually every single year except for last year, of course. And I knew this person, but not really. And she said, you know, a bunch of us are going to dinner tonight. Do you want to join us? And I was like, yeah, sure. I mean, I was kind of by myself. I didn't really have anything to do. So I thought, sure, why not? And so I was the last one to show up for dinner, and the only seat available was next to her. And so I sat pretty quiet during dinner. And at the end, as everybody was kind of breaking up and leaving, she said, you know, if there's ever anything you need, please let me know. And in a very quick response, I said an internship at SSA would be great. And she said, okay. And I really had no idea what I had gotten myself into in such a good way. And so off I went. I was working full time during grad school, and so I had to figure that out with my boss. So off I went to rent a room with a guy and his wife. Now this was in the days before Airbnb. So so I rented this room in their house, really, again, not really knowing what I was getting myself into, and worked on the go live of eHealth Exchange before it actually went live, and then through the go live, and then a little bit on the back end of the go live. And the reason why I say it defined my career is because from that, I was commissioned to do a case study. And that case study, which then led to my dissertation, which then led to another study, are the only studies, even to date, that have ever used federal level data to show value for eHealth Exchange. And so I'm pretty proud of that work. Like I said, it delayed my graduation by a year, but it was so worth it. And in the end, you know, when I delayed it by a year, of course, that was agony. But now in retrospect, it was probably the best thing that I could have done. And so I tell that story because the defining moment in that story was this kind of flip answer after dinner. It was like, yeah, an internship would be great. And then I'm going to tell a story about how I got to UAB, because there's one commonality, and that's another flip answer during dinner. So I was at the same conference and at a big table with a bunch of people, and there was a guy there who I did not know him, but he and I knew somebody mutually. And he leaned over to her and said, you know, do you think she, meaning me, is looking for a job? And she said, I don't know, why don't you ask her? And so he said, are you looking for a job? And I said, actually, I am. Now, I thought he was at University of Illinois at Chicago. And I came home and I told my husband, this is at the same conference, by the way, this is at the HIMSS conference. And so I came home and I told my husband, I said, what do you think about moving to Chicago? And I was like so excited. And then he sent me the posting, and I realized that it was really Alabama, and really the only thing I knew about Birmingham was what I had learned when my kids were studying civil rights in elementary school. And so I had to do a lot of research on what would that mean to set myself up potentially for a job at UAB. And I'm so glad that I did, because you'll hear in a few minutes some of the innovative work that me and my colleagues have been able to do at UAB. And I'm convinced that some of this work could have only happened at UAB. I think it's the collaborative spirit at UAB and the way UAB fosters innovation, certainly in our department. Where we really have a lot of freedom to think wildly about things. And so that's a little bit about me and my background and how I got to UAB. As was mentioned, I'm the director of graduate programs in health informatics here. And so I want to talk a little bit about our program. We have 4 ways to get a health informatics education in our program. One is through an AMIA 10 by 10 program, and that is directed by Dr. Ida Berner. And you'll see some of her research in a moment on one of the future slides. And then another way is we have a clinical certificate in health informatics. Then we have a Master of Science in Health Informatics, and we've got 3 tracks, and I'll talk about those in a moment. And then we have our Administration in Health PhD, and there's 3 tracks off of that. One of those tracks is Health Informatics. And I think we're one of the few, if not the only in the country, that prepares CEOs or health administrators or people going into the academics of health administration from a health informatics perspective, or at least with the option to do so. So this is a little bit about our program, and I want to show you the kind of what it looks like. This stops at the master's level, but you'll get an idea of it. So the first red box up there is the AMIA 10 by 10 course. So HI 611 is the AMIA 10 by 10 course. And then the next 3 courses plus 611 are the clinical certificate. The reason why I show them like this is because if you took the AMIA 10 by 10, then and you decide to go on for your certificate, that course counts. So then you really only have 3 additional courses to take. If you do the certificate, which is 4 courses, then those 4 courses count towards our master's degree. And so you enter the program at the HI 620, which is a spring course. You can either take it that first spring or you can take it the second spring. And then you just fall in step right in line with our master's students. If you come in as a full-on master's student and don't come in through the AMIA 10 by 10 or the clinical certificate, then you start in fall year 1. And the first year, fall, spring, summer year 1, are all of our core courses. And then you decide what track you want to take. And then down below that, you see our tracks. So we have 3 tracks. We have a data analytics track, which really gets into a much deeper dive into data analytics for healthcare and data visualization of healthcare data. And then is our user experience track. And people tend to think that health informatics is all about data. And that's one key perspective. However, if you don't consider the human-computer interaction of getting the data and people who use those systems, then you miss a very, very big part of health informatics. And so we are the only health informatics masters that focuses on user experience for healthcare. And there are other programs that focus on just human-computer interaction or human factors. But we focus on user experience for healthcare, which is not just about human factors design and human-centered research design, but it's also about the user experience with machines. And so in this track, it focuses more on the qualitative side of health informatics, whereas data analytics focuses on the quantitative side of health informatics. And then we have our research track. Our research track is brand new this year. And we already have a fair amount of interest in it, which is very, very exciting. Our research track is a collaboration with the Informatics Institute of the School of Medicine, led by Dr. Jim Cimino. And that track gets into biomedical informatics. And so health informatics is more about healthcare delivery, systems used in healthcare delivery. And biomedical informatics is more at the cellular level, includes more biology, and it's more of things that you hear about: genomics, proteomics, things like that. So anything that ends in the omics suffix is usually included under biomedical. And then there's 2 electives that are offered. There's two mandatory classes, which are methods courses, and then you get 2 electives. What is common across all 3 tracks is our leadership course. So we have one core leadership course, leadership theory and development, that is HI 624. However, one of the things that we pride ourselves on is graduating students that are meant to be leaders. And so leadership is really baked in throughout every single course that is taught in our program. And then we cap it off with leadership theory and development. And then there's a culminating project for the MSHI program, and that is a capstone. And you see that there, 673, 674, and we don't yet have the number yet for the research track on the capstone. And the capstone is a culminating project. It's an applied project where you solve a health informatics problem. And so these projects, they take all kinds of twists and turns, and they're really student specific. And so we are not prescriptive over what kind of project it needs to be. If the student can't find a project, then we've got a list of projects that the student can use. But usually the student finds their own project, often at where they work. Sometimes in a different area than where they work, but they're able to find a project there. The capstone is a 3-semester course, so you see it first in the fall as 671, 672, and then, as I mentioned, we don't have the number yet. You see it then in the spring, 673, 674, and then you see it again in the summer, 675 and 676. The reason why we split it over 3 semesters is to give people an opportunity to do something very meaningful with a lot of depth. And a fair amount of these projects actually wind up getting published. And so it's quite satisfying to be able to come out of the MSHI program with knowing that you've got something that's manuscript ready. Our program is 2 years and 45 credits total. So I'm going to talk a little bit about the informatics research that comes out of our department from the faculty that teach in the informatics program. I know my own research best, of course, and so I don't have any descriptions around my own because I'm going to talk about it. But then I have descriptions around some of the faculty research that we're doing, and I'll talk about that as well. And so right now, I'm in the process of developing a few information systems. The first one is a collaborative health information system for peer support specialists. We call it CHIPS, and I'm developing this for the state of Alabama. So what happens in substance use, abuse, and recovery is that they have peer support specialists. And so think of this a little bit like AA or NA on steroids. And there's assessments that are being done and placements that are being made and things like that. And so they don't have any way to document the information. Currently, they're documenting it on paper and then putting it into an Excel spreadsheet. And so I have a grant from the state of Alabama, from Medicaid, to develop this system. I've been working on this for a couple of years. we had some stalls at the state level because of COVID. And now we're back on and it's ready to be deployed. We think it's going to be deployed probably within a couple of weeks, I think by mid-April. We're right now just working on user accounts and things like that. So I'm super excited about this project. And one of the things that I do in my development of information systems is development for social good. And so my very first project that I told you about when I was in grad school was actually around disability, people with disabilities and disability determination. And if anybody has ever applied for disability through SSA, you know what a horrendous effort it is. Now it's all electronic. And it's electronic because of the work that I did when I was at my SSA during my internship, and then a lot of work that I did afterwards. And also including my work that I did on eHealth Exchange. And so I like to develop things that have a social good. And so CHIPS definitely has a social good, and I'm excited about that. The next 3 bullet points have to do with COVID work. So I lead the GuideSafe initiative, which is health check, and we have an event passport and the GuideSafe exposure notification app. And so, I expect that most people are probably familiar with Health Check and the exposure notification app. We just launched a brand new version of the exposure notification app. And so if your phone did not automatically update, then I encourage you to go to the Apple or Google app markets and download it again. It's got a new look and feel and some new features, and we're super excited about that. Then the next 2 bullet points, a vaccination dashboard and vaccination adverse events. I'm going to show those at the end. I'm going to go through those and show those. So I'm not going to talk about those right now, but I'll talk about those in detail when I actually show the work that I've done on that. I'm also working on a project to use social media to understand the use of adverse events for drugs that are used off-label. And so by off-label, I mean that the FDA approved them for one thing and physicians are prescribing them for another thing. And so the drug that I'm studying right now are fluoroquinolones. Cipro is one that you may know. That's a common one that people get for bladder infections and other broad spectrum needs. And so I'm working with the forensics lab at UAB, Dr. Beth Gardner and Gary Warner, and some people there, some students there. This is a grant that I got from the American Cancer Society in trying to understand this. And so what we're doing is we're combing the social media for what people are saying about these adverse events. And what it's showing so far is what we had suspected, is that it leads to a lot of neurotoxicity and neurosequelae. And so we're hoping to then leverage that information for a larger grant. I'm also PI on Center of Excellence for Opioids at UAB, which is a state-funded grant out of Alabama Department of Mental Health. And a subcomponent of that is Opioid Watch, which I work on with my colleague Ben Ozeiden. And that is to build an information system to house opioid and substance abuse data all in one place. So right now the coroner has their information and some of the community resource centers have their information and UAB has its information, and it's just all over the place and you can't query anything. And so that is for that one. And then another project that I'm working on with 2 of my colleagues, and these are both in my department, Dr. Zengel and again, Dr. Ozeiden, is doing a text mining topic analysis of COVID scientific literature. And so that's a little bit about my research. As I mentioned, I'll go back and at the end, I'm going to show you these dashboards. And now a little bit about other research that's coming out from other health informatics colleagues that teach in our program. So Dr. Ida Berner is working on integrating a genomic risk assessment for chronic disease management in diverse populations. And what this is going to do is it's going to examine the impact on patients and providers of integrating this genomic risk assessment score into the electronic health record. And so, so earlier I talked about anything that ends in the omics is kind of more under the biomedical informatics, and genomics is in that space. And then Dr. Shannon Hauser, who also teaches in the Health Informatics program. And some of these faculty teach in other programs in our department, not just in Health Informatics. Shannon and Hyan, the next two, they teach across our department. But they teach in Health Informatics and they're doing Health Informatics research. And so I wanted to include it here because I think it's important to show the diversity and the broad spectrum of research that health informaticists do. And so looking at Shannon's research, I've highlighted 4 studies here. One has to do with merging multiple patient identifiers. And we all understand what an entanglement that is of just patient identifiers. So I'm sure that that's a really interesting study. And then also looking at cancer registrars' perceptions. So that's the user, right? Users' perceptions of quality and use of cancer registries. And so that's kind of in the user experience end of things. When I talked before about our 3 tracks, that's in the user experience end of things. And then looking at using a chat device called WeChat and depression in older populations. And then finally looking at patient clinical documentation in a telehealth environment. And, the thing that's interesting about telehealth and telemedicine is that, it took a pandemic for Medicare and Medicaid to actually pay for that. And I think clinicians knew all along that that was a great way to deliver medical care, but it took a pandemic to actually get it paid for. And so I think her research here is probably extremely timely. And then Hyan, Chu, and Shannon have another couple of studies together looking at EHR adoption. And this is using a secondary data set to examine EHR adoption. So I am going to stop there with that. And I'm going to actually share a different screen. And now go through these dashboards that I had mentioned. So this is a vaccination dashboard that I'm working on with some colleagues at the PathCheck Foundation. PathCheck Foundation is a spinoff from MIT. And I've been doing a lot of work with them on a variety of things. I'm going to show 2 dashboards today that are a result of my collaborative work with them. So just to orient you to what you're looking at, in case you want to go into this, the URL is vax.uab.edu. So vax.uab.edu. And so this first map up here is of the US, of course, and it has a slider here where you can look at vaccinations administered over time, and you can see the change in the density shown in color here. And you'll notice that the scale changes at the same time to be able to accommodate the changes. And so here we are now. There's about a day lag in some of the data, not in all of the data, but in some of the data. And so this one, there's a day lag, actually 2 days lag. You see March 29th there. And you can hover over, I'm going to hover over Alabama. You can hover over a state and you can see the population, how many people have gotten the first dose and what percentage of the population that translates to. And then the same thing with the second dose. And so if you compare to New Mexico, which has a deeper density, right, deeper blue, and you can see why, right there at almost 38% of their total population has received their first dose. So up here are total vaccinations by a manufacturer. And then here we can look at the top 10 states and where they are relative to herd immunity, thinking that herd immunity is probably 70%. We don't really know. Herd immunity is disease specific. And so the experts are thinking somewhere between maybe 65 and 80%, but we really don't know. We've used literature to settle on about 70%. And so you can see that, that this information here is just a different translation of this information here, and it shows the top 10 states. And so, so you see that New Mexico, almost there, again, 38% have had their first dose. Now, if you want to travel out of the country and you want to see where to go, then you can look at countries that are approaching herd immunity. And Israel would be my choice of where to go, where almost 75% of the population have been immunized. And so UAE might be next on my list, and then you can look down the list there. So that's the top part. Then we get to the middle part of the dashboard, and this is the dose availability relative to doses administered. And so what we're looking for is we are looking for something to get green, right? We're looking for something close to the 60% mark. And this comes up automatically in alphabetical order. And you can see Alabama is up here. And the fact that it is almost the darkest circle on here is not really that great. Only Georgia is behind us. But if we look at Alabama, we have almost 38% of the doses available for the population, and about 23% have gotten the first dose. You can click on this and add more states or subtract states and look at who you want to look at. And so our next chart on the dashboard shows just the last 15 days. So this is to show trends, and it's just the last 15 days. It auto-populates with the top states, but you can compare your own states and you can clear them, and then you can add states that you would like to add. And so so if we go over here, all of this is set relative to the trend for the US, and then they're listed in order with whoever's first. So we already discovered up above that New Mexico was top, but we could look at just the southern states if we wanted to, and let's see, maybe do, I'm not that great with my geography, but let's say we just look at those southern states and that's it. And so we can see that Alabama is not looking great compared to the other states. And for a pretty long while, we were above Georgia, but it looks like Georgia has caught up to us, and you can kind of see when that happened. You can see that we're kind of like neck and neck here, but we're pretty far below everyone else, and we're certainly far below the national average. Whereas when you look at the graph, the way it's populated, most everyone, the top 10 anyways, are above the national average. So we still have some work to do in that area. And so the last information that I'm going to show you is in the tabular format, and this is vaccinations administered across the US, and you can do sorting and things like that with this one. I'm not going to do anything with this one. This is pretty self-explanatory, but you can get in there and you can play with it. Next, I'm going to show you the adverse events dashboard that we did. And I've used this dashboard numerous times when people have expressed to me that that they are fearful of getting vaccinated. I respect that getting vaccinated is an intensely private health decision. We put together this dashboard because there's valuable information that's out there, that's public, and needs to be seen by people. And so this shows, again, vaccinations across the US, and then the adverse events that have been reported, and adverse events per million. 367 is actually a low number. And so just to orient you to this uses VERIS data, which is CDC adverse events data that are reported. This first graph up here is by age group and gender, and so you can activate or inactivate certain things. And then next is the summary of adverse events by manufacturer. And so it's actually the manufacturers combined, but you can see which one has more adverse events. And it could be that there's just more Pfizer that has been given. I'd have to look back on the other dashboard to see. But this is this shows you that there's only been 1,920 deaths, and there's another one that we have that goes a little bit more into the deaths. And so these are categorized according to the data, but you see that most people have recovered. And when you look at what the symptoms are, there are things like headache, fever, things like that. And so those are pretty easy to recover from. In terms of deaths, and we look at who's dying, it's hard to assume causality. I've read through the death reports, and some of them are like, I don't really know that death was definitely because of the vaccine. But nonetheless, that's how they're recorded. And so the primary age group is greater than 80. We have some thoughts about why that might be. And if you remember who was vaccinated first, it was people in long-term care situations that were vaccinated first. And then the next largest age group, with being just about a third, is the 65 to 80 group. But definitely the greater than 80 age range is a bulk of the deaths that have been reported. Okay, so then down here, I talked about the symptoms reported. That was everyone. This is females, if you're female and interested in that, and if you're male and interested in that. We don't know why more males have reported symptoms than females. Of these, we just don't know why, but so that's just kind of interesting. And then we look at who was COVID positive after vaccination by age group. So one of the things that I'm finding the public doesn't really realize is they don't quite understand is that if you're getting 2 vaccinations, you get your initial one and you get your booster, that you're really not fully protected until after the booster. And that even after the booster, it takes a couple of weeks to be fully protected. So people don't really understand that. It's also possible that you could be asymptomatic and then you get tested. And even though you've had the vaccine, you were asymptomatic when you had the vaccine. Nonetheless, here's the age group. Again, the 85 and over age group is a large portion of that. And then we look at adverse events by state, and we see that Alabama has had 22 deaths. This is again tabular, so you can do some sorting and things like that if you wanted to. Only 400 adverse events, 22 deaths. And I've looked, you can go into the VERS data and look at these case by case. And when I last looked at them, it was things like a 90-year-old, an 85-year-old, an 88-year-old, and you just have to wonder, did they have something else going on? There was one, when I last looked, there was one that was a 44 or 45-year-old, and you have to wonder if there was something else going on there. It was, I think with that one in particular, it was 3 days after the vaccination. And so, you just don't know. So those are the 2 dashboards that have come out of the research that I mentioned that I have done. I will stop sharing, and there's a question in the chat that I'll answer, and then open it up for other questions. The question in the chat is, does this program factor in people who are from one state who travel to a second state to get vaccinated? That's a very good question. And so the vaccination data are from what people what they document on their vaccination sheets. And so if I went to Georgia, let's say, to get vaccinated, I would likely put my home address. I mean, I don't know why I would put anything other than my home address. And so that would have me vaccinated. It would show me vaccinated in Alabama. I don't really know the degree to which many people cross state lines to get vaccinated. Much of this is engineered by public health departments, and so those are usually state-run. I think Alabama's a little bit different in that UAB has such a major presence in statewide vaccination, but most of them are at the state level. So I'm not really sure how many people would cross state lines.
Yeah, so I was asking that because I'm from Georgia, and so as a college student, like I put my home address as Alabama address. So I was interested in that, but also like vaccine distribution from Georgia is not as good as over here. And so like early on, teachers from Georgia traveled to Alabama, got their vaccines, and then went back to the classroom. So I was just interested in that.
Yeah, I think it's a great question. And so you being from Georgia who put your Alabama address, that would be Alabama. Them being from Georgia and hopefully putting a Georgia address would contribute to those numbers, but I bet you that's not more than 1% of the total population. I just don't think it's that big, especially the further west we go. The states are larger, and unless you live on a border, that may not be as much of an issue. I think certainly in the Northeast, where, you know, in 20 minutes you're in another state, then definitely. So I'd like to open it up to questions and see if I can answer any questions. So John says, what technologies do you use to develop all of these? How would you choose the technologies? How many programmers do you have? How many research staff does it take to make all these projects possible? Oh gosh. Oh boy, those are really great questions. And so so it takes a lot of people. The health check work, so let me start there. The health check work was initially led by my colleague in Health Informatics and in our department, Dr. Mohan Thiramalai. He initially led those efforts, no longer leads them, but did initially. And the exposure notification app efforts were initially led by Brian Rivers and Rajesh Pillai out of UABIT. And that's no longer. The reason why I say no longer is because things get to a certain level where they're not, you lose scalability. If you keep them at their certain level, you lose scalability. And we were losing the ability to scale to populations that we needed to scale to. And so, so health check for many, many months has been turned over to a company called Guideway in Birmingham. And they do the day-to-day operations and development and support for health check, and they do a fantastic job. And that has been a great thing because they have allowed us to scale in a way that we could not scale when Dr. Thiramalai was leading those efforts. Same thing with our exposure notification app. That is now being led out of PathCheck, which is the same organization who I'm doing the dashboards with and some other work. And for the same exact reason, you get to a point where you just cannot continue to scale if you want to be sustainable at a scaled rate. And so, so both of those organizations, Guideway and PathCheck, have a lot of resources behind them. And that's part of what allows us to maintain sustainability and scale, is because of the amount of resources that they have. So some of the other work, the dashboard work also has a team of programmers and engineers behind it. I lead it, but I don't actually get in there and do the coding and do the work. These are projects that I lead, where I'm the PI on them, and things like that. And so behind me, there's an entire team that executes on my vision and grants that I submit and things like that. And so I'm very fortunate that way, to have, you know, such a reliable team that's super, super easy to work with. Having a lot of projects is difficult to maintain. I like having a lot of projects, and I have a list. I use OneNote, and I have a list of where all my projects are and who's doing what and what kind of publications are kind of in the pipeline with those. And it really helps keep me super, super organized so that I can devote time to these projects. Health informatics, kind of by definition, is a horizontal discipline where you can take verticals wherever needed. And so, so before I started all this work with opioids, I did not know anything about opioids, but I know how to develop information systems. And so it's just a vertical into opioids. Before COVID, I didn't really know anything about communicable diseases. I knew about public health, but not really in that way, not really in terms of public health surveillance, disease surveillance, things like that. I didn't really know anything about that, but having this horizontal focus allows me to take verticals. And because I can develop information systems, I can do that. I can drop down into that. So great question. Are there students involved in developing any of these? Yeah, that's a super, super question. So in the work that I showed from the faculty, there's a lot of student involvement. And I just didn't put that up on the screen, but there's a lot of student involvement, primarily on the ones where there's publications and things like that. We really like to get students involved in that. And to the degree that we can, get them involved from the very beginning. In terms of my work, there's a lot of students involved in my work. In my COVID work, on the dashboard work, there's a lot of students behind the scenes on that are volunteering their time for development and things like that. On CHIPS, which is the information system that I'm developing for the state of Alabama, I've had students on that pretty much from the very beginning. And we've gotten several publications out of that. I mean, it's really a real life use. Some of my other work, I see Heather Martin on, so she's a PhD student on the health informatics track. And so I don't know if I involve her in my work or she involves me in her work. But it's been a really great relationship, and her work is around also around opioids and around PDMP monitoring. And so I got a grant from Jefferson County Department of Public Health that she's working on right now to develop pain and opioid education for all of the schools of health profession across the state of Alabama. And this will, she's working with subject matter experts where she has to interview them and come up with surveys and put together the curricula. And then she'll work with a professional instructional designer to actually make that happen. And this will provide a very good foundation for her dissertation work, which is really more around PDMP, which is an information system, state level and national level, around prescription drug monitoring for Schedule II drugs. And so those are some of the things that I can think of offhand. As I mentioned, our students, our MSHI students, do a capstone. And so the students all have their own project. It's kind of like a mini dissertation. We don't call it that, but they do a proposal. They have to get IRB approval, and then they do a full-on study, and it's done independently. And so that is, if they don't have the chance to work with a faculty member, that is the application, a real-world application in the real world of health informatics. Let me see, asking to see how students would be trained. Okay, so I just addressed that part of it. The second part of this question, which I hadn't seen before, was asking to see how students will be trained to face real world problems. And so that comes in if they can work with a faculty member or in their capstone. It's difficult for students who are working full-time and going to school full-time to work with a faculty member. Going to school full-time and working full-time is already like 2 full-time jobs. And I worked full-time when I was in graduate school and went to school full-time, you know, and did all these other things. And it is difficult, especially if you've got little kids at home or things like that. And but we're always willing to work with students. Oh, I mean, always happy to do that. And those of us that have grants usually write students into the grants. In the work that I'm doing on the social media work on fluoroquinolones, I've got 3 students working on that. What percent or extent of programming coding is required for admission and graduation? So 0. You don't have to have any experience with that coming in. If you don't have any experience and we set you up taking a SQL class, that's just on LinkedIn Learning, and you supply us with the certificate, and then you learn what you need in the program. And so we don't require anything. We teach you what we need for you to know. You come out being Mendex certified. Mendex is a low code solution that is being used in healthcare a lot. And so you use that in a couple of courses and you come out being Mendex certified. So I noticed that we're about a minute over 11 o'clock, and I briefly had my my email address up on the screen. I'll put it in the chat, and you're more than welcome to email me with any questions that you might have, or you know, I can stay on. It's all up to you guys.
Thank you so much again. It was great. And also I wanted to add that we recorded the meeting and we will post it on our YouTube channel. We will share the link with everyone, so the recording will be available. And with that, if we don't have more questions, I think we could finish here.
Well, thank you again very much for having me, and thanks for the great questions. I appreciate it. And again, my email is in the chat. You can find me in the Outlook book, but feel free to reach out to me if you have any questions. And I actually just noticed that one of our students is on. I hadn't noticed him before. I don't know, Chirag, if you want to say anything about the program, or I don't want to put you on the spot, but that's possible, and you guys can reach out to him if you have any questions as well.
All right. Have a good day, and bye-bye.
Bye. Thank you.
Thank you.